for improving care with intravenous iron. So if you're watching, this is a picture of me, and I'm a hematologist and medical oncologist at the Pennsylvania Hospital, part of the Abramson Cancer Center in Philadelphia. And so I'm going to read a couple of pretest questions, which we'll go over at the end, and hopefully you'll be so enlightened, you'll jump right to them at the end. So here's question number 1. Patient JL presents to your clinic reporting fatigue and general weakness. You order labs, which reveal her serum ferritin is 345 nanograms per ml. Transparent saturation is 14%. Her hemoglobin is 8.6. You diagnose her with which one of the following? Absolute iron deficiency, functional iron deficiency, iron overload, anemia without iron deficiency. So think about that. We've got a few more, and we'll come around at the end with some answers. Here's our second pretest question. For patients with cancer-related anemia and/or chemotherapy-induced anemia, IV iron has been shown to achieve which of the following? Reduce transfusion requirements, increase erythropoiesis, enhance energy, activity, and overall quality of life, or all of the above. Our third question. In a hyperinflammatory condition like cancer, hepcidin levels are often elevated. Which of the following iron supplementation strategies aims to address this common finding in cancer-related anemia or chemotherapy-induced anemia? So here are the 4 answers. Oral iron should be used preferentially and at higher doses to overcome reduced intestinal absorption. Intravenous iron should be used preferentially as it circumvents reduced intestinal absorption and overcomes restricted ferroportin transport. Or oral ferric formulations are preferred as hepcidin only disrupts oral absorption of iron in the ferrous form. Or oral iron should be used preferentially due to patient tolerance. That's a long one. Next question. Which of the following is true about IV iron safety? Severe hypersensitivity reactions are extremely rare with next generation IV iron products. Fishbane and/or the CARPA, and we'll get into that, reactions should merit treatment discontinuation. Molecular weight has minimal impact on the safety of IV iron products. Or finally, IV iron can generally be used without concern in cases of active infection. So which one of those is true? Next question. JL returns to your clinic after 3 weeks on oral ferrous sulfate, so oral iron. She reports bothersome stomach pain and constipation, says she still feels tired all the time. When you recommend IV iron, she says she asks about potential treatment-related risks. Which of the following are accurate patient counseling points regarding IV iron-associated hypophosphatemia? First answer, hypophosphatemia is not a clinically relevant consideration when selecting IV iron therapy. Or, trial data suggests the greatest risk for hypophosphatemia among currently available IV iron products is with ferric derisomaltose. Or, trial data suggests the greatest risk for hypophosphatemia among currently available IV iron products is with ferric carboxymaltose. Or, serum phosphate monitoring is only warranted in patients receiving IV iron for anemia of chronic kidney disease. All right, so those are your brain teasers. Think about them. Let's now go through our presentation, see if we can enlighten you and help with those questions and answers. So first, we're going to set the stage, understanding iron deficiency in the context of cancer-related anemia. So for this first part of the talk, learning objectives will be to talk about iron absorption and metabolism and distinguishing functional versus absolute iron deficiency. It's unfortunate terms. Absolute iron deficiency makes sense. You're out of iron. Functional is you are not out of iron. You have plenty of iron, but you can't seem to mobilize it or use it or absorb it. It's a sea of plenty, but not getting to the right place. So we're going to differentiate those two. And the second thing we'll talk about in this first part of the talk is cancer-related anemia. You'll hear us say CRA, or chemotherapy-induced anemia, CIA. So let's get into that. So I'm looking at a graphic of iron absorption. I'm going to spend a little bit of time on this. How is iron getting in and around the body and transporting? So we eat it, of course. And so the stomach converts it to a form where a ferroportin, this transporter, can take it to circulation. Now, you'll see on this graphic hepcidin. I want you to disregard that for a moment. I'm coming back to that. So you eat it, it's transported to circulation where it's available or to storage. And the second part, lower part of the graphic, shows you that storage. So it can get to storage. Here we see the spleen, could be the liver, could be the bone marrow. So it's in storage, and it's stored as ferritin. And then as it's, I think of it as your gas tank. And as you need iron from your gas tank, the storage is available to then go to circulation. You see here serum transferrin, and it goes circulating to the bone marrow where erythropoiesis is happening, and you make blood. All right. What's the deal with hepcidin? Let's take a brief journey back in time to the caveman era. Caveman goes out today to kill a tiger for cave family. For the week, comes back and has to tell the wife that he's stepped on a nail. I'm not sure what a nail is doing 30,000 years ago, but let's go with it. And his foot looks infected. She says, oh, well, there's no penicillin for 30,000 years. You're going to die. So evolution learns that bacteria, microbes of all sorts need iron. And so whenever someone is inflamed, in this case, a nail infection or cancer or autoimmune disease, this hepcidin, now I'm looking at the graphic again, this 25 amino acid is made by the liver, hepcidin, and it says, thanks to evolution, let's play hide the iron. We don't want to perfuse this foot infection with iron. So it dials way down oral absorption of iron. And it also takes all the iron stores and says, we want you to stay there. So it locks them up. So in the first part of the graphic, you see hepcidin is blocking intestinal absorption. In the second part of the graphic, you see it is blocking it from getting out of storage. So it stays there. And sadly, it stays in storage form and it cannot move over next door to erythropoiesis to make red cells. All right, let's move on. So we're going to do this, and the next slide hit again about the same concept. So at the top, you see absolute iron deficiency. So we're out of iron. What's the definition? Serum ferritin less than 30, or transferrin saturation less than 20%, or both. In this case, it should be both. I should mention that that's for those of us not inflamed. If you're inflamed, the WHO has changed the definition of iron deficiency ferritin of less than 80. So a cancer patient with a ferritin of 60 would be considered potentially iron deficient. All right, so here in someone not inflamed, absolute iron deficiency, under 30, under 20% transferrin saturation. And the graphic here is to show that iron coming in is not enough. And despite having some ferritin, there's not enough to go to the right here to make these pink red cells. And then I've mentioned functional iron deficiency, where it means you have plenty of iron, but it can't get to the right place. Now, here are the definitions. See at top here, the ferritin, we're going to say at least 100. So above 30, remember the inflamed person, 80. So let's say above 100 to high number. And the circulating forms of iron, remember, we're playing hide the iron from that infected foot or from the bone marrow, we're hiding it. Saturation circulating forms are under 20%, and storage is high. The graphic is showing iron is available. It's locked here in ferritin. Hepcidin blocks it from getting out. And so the bone marrow, once again, does not see enough iron, and you are functionally iron deficient as opposed to the previous absolute iron deficient. Now, on this next slide, the NCCN, I think, has this graphic, but it's here for your reference. I'm not going to go through the whole thing, which is a lot, just to kind of highlight these first two areas. So here we see a serum ferritin, and that's what the whole black bars are across the top, less than 30. Serum ferritin less than 30 and transferrin saturation less than 20%, you have absolute iron deficiency. As opposed to the ferritin is high, let's take 300. Storage is high. Available circulating iron is low. This is the functional iron deficiency. And there's some other variations on this theme of iron overload, which is not really our topic this evening or today. And one more graphic. This is entitled Cancer Chemo-Related Inflammation Reduces Iron Availability, which we've said any inflammatory condition, whether it's infection, cancer, autoimmune. And so hepcidin says, play hide the iron. Don't absorb it from the GI tract. Don't allow it to leave storage. And so the bone marrow simply does not have enough iron. It can't differentiate whether it's absolute or functional. It just simply does not see enough iron. In this case, with cancer, it's hepcidin-induced for the reasons we've said. All right, so a busy slide, cancer-related anemia. Why? Well, highlighted here in this box is we give things that make things worse, let alone the iron business. So we give myelosuppressive chemotherapy, we give myelosuppressive radiation therapy, and we give some other medications. Immunotherapy is part of an inflammatory situation many times, so it's not actually bone marrow suppressing by itself, but participates in inflammation. And of course, there's other infections that may go on to round out why someone might be anemic. All right, a pretty slide, looks complicated. In fact, it says it's complicated, but I think it's actually not so complicated, just highlight some things. Let's go around counterclockwise. So we'll start over here. Why is our cancer patient anemic? Well, our patient may bleed, a GYN tumor, sometimes GU, they could bleed. They could be poorly nourished. Cachexia, malnutrition can set in. This is not that common, but if you're not eating enough, you may not have enough iron coming in. Occasionally there's hemolysis, that's not very common, but not so, I should say common, not so uncommon, is CKD. The kidney may be offline. Remember, if you have no kidney function, your hemoglobin's 6, so we need our kidneys to make it the rest of the way. Remember, 12 and above, I'm sure this audience knows. For females, 13, 13 and a half and above for males, the difference being testosterone. Males have androgen, females do not. But without a kidney, you go down to 6. So any renal insufficiency can be somewhere on the way down from 12 to 6. Of course, here going around to the right, our chemotherapy or radiation therapy can suppress the bone marrow. And of course, the bone marrow could have tumor in it. And finally, coming around here to the cancer patient inflamed, makes the hepcidin and locks it up in storage, not available to the erythron to make red cells. So it's actually fairly straightforward, this slide, I think. All right, so who cares if you're anemic? Well, Mother Nature cares, 12 and above females, 13 and a half above males. Does it affect us? It surely does. So here is a very simple study I'm pointing out to the graphic here. We have an anemic versus a non-anemic breast cancer patient. And while the bars may look fairly close, they actually are significantly different in functional assessment chemotherapy or cancer therapy anemia score. And the non-anemic patient has a better functional state than the anemic patient. Not shown here is a wonderful study I want to mention done back in the early 2000s, first author Crawford, that took patients on Apoetin alpha and looked at their quality of life change. If you go from 7 to 8 to 8 to 9, 9 to 10, you get the idea, all the way up to 13. So we thought, well, it's going to be a big difference in quality of life when you go from 7 to 8, 9, 10. It turns out each unit increase does improve your quality of life, but the major improvement comes when you get to 10. 10, 11, 12, 13, you have a much bigger gap delta in your functional improvement. Well, why is that? We think actually it does make sense. When you're going from 7 to 8, 9, 10, you're still tired, fatigued, too much to get off the couch, so to speak. And so you report improvement, but you still aren't doing lots of what you should do for typical quality activity daily life. And so when you get 10, 11, 12, 13, you really feel like getting up and around now, and patients report scores that are higher delta. So it does make a difference to go from 7 unit-wise, 8, 9, 10, 11, all the way up to normal, which is why we humans are that number. All right, so that's kind of our warm-up background. Let's go to what's called the main event. We're going to talk about cancer-related anemia, chemotherapy-induced anemia, and what about intravenous iron? All right, our learning objectives here are highlighted. We're going to talk about clinical trials of IV iron in these conditions, cancer with or without the chemotherapy. And I sadly am old enough to remember Imferon. Hopefully no one remembers that, because boy, that was terrible. It was full of side effects. You had to give a Z-track, usually in the buttocks, and it was rather unsafe. And so we've come a long way. This next bullet says next generation IV iron products. have improved the safety, and there's now, you'll see some slides coming, many early and late generation IV iron products that left Imferon behind. It's off the market. And we'll go through some consensus guidelines covering what's probably known to most of you, ASCO, ASH, NCCN, Esmo, for how to use IV iron products, ESAs, sometimes in conjunction, or sometimes just the IV iron. So let's get into the data. So we're going to look at IV iron clinical trials in cancer-related anemia or chemotherapy-induced anemia, CRA or CIA. And in this somewhat busy slide, we're going to look at IV iron in cancer. And I've highlighted for you in red, there's at least, before we get to the red, there's 8, maybe now 10, 12 randomized trials comparing iron in ESA or ESA alone, thousands of patients. And in red, hemopoietic response is always better when you give iron with the ESA. But how do you give it? Well, the next line shows you that this benefit is virtually exclusively to the IV iron. Because remember, this patient's inflamed. And so hepcidin has shut down the oral absorption. And no surprise, the IV iron, which goes around that, has made the major difference, as you see here in the response rates, ratios, and very strong p-values, that the IV iron ESA is much better than oral iron ESA, where there's almost no effect. It also can improve red cell transfusion requirements. So we increase hemoglobin, decrease red cell transfusion requirement, and concluded down below, addition of iron IV ESAs offers a better hematopoietic response, reducing red cell transfusion, improving hemoglobin levels, quality of life, and it's well tolerated, as we'll show you. So let's get into and talk about the data. So IV iron clinical trials in CRA and CIA. Here you see there's now, as I mentioned, some 8 to 12 trials of using ESAs in combination with IV iron. And the first one was done by our colleague, Dr. Michael Auerbach in Baltimore, who in this graphic, you're seeing quality of life, you're seeing response and quality of life changes called energy, activity, and overall quality of life in the patients he had. They had CIA, chemotherapy-related or induced anemia. They were getting a potent alpha with or without what? So in this first bar, with or without anything, so no addition of iron. Here, oral iron, but look at the dramatic change when you get to bolus iron. They had a weekly iron dose, getting weekly potent alpha, or one large total dose infusion, both significant improvement in quality of life. Well, you presume that that went along with improvement in transfusion and hemoglobin, and sure enough, it did. So here in a different study, not the same study, this is by Bastide. The study here is again CIA patients getting darbepoetin alpha with or without IV iron. You can see the transfusion requirement in red here on the left, early on or later on, is much improved with IV iron versus not. So IV iron with ESA. And then how about the ability to hit a certain target hemoglobin, the so-called hematopoietic response? This same author and the IV iron, the percent patients hitting the target, so-called hematopoietic response target, is greater with the IV iron in both graphics, depending on how early on in the study and what the target is. So clearly in these 2 studies of some 12 now randomized, the IV iron with ESA always better. So why not try IV iron alone? If you think about it, this should work, because we've said, well, it's nice to have the ESA to stimulate the erythron to make red cells. The erythron's looking for a fuel. Remember, the patient's inflamed, the fuel is not available, it's locked up. How about if you pour it in, intravenous iron, and it doesn't have a chance to get locked up, it goes right to the bone marrow, which is trying to get fed and make red cells. So makes sense, does it work? So here we list a number of the authors of these trials, giving IV iron only as monotherapy in CIA. This first study we'll review is called Ironclad, and it is a double-blind placebo-controlled trial. It randomized patients to ferric carboxymaltose or placebo. They were getting at least 4 weeks of chemotherapy remaining. They were getting chemotherapy of various types and various tumors for non-myeloid malignancies, and they randomized to FCM, ferric carboxymaltose, actually twice, 15 milligram per kilogram, 7 days apart, up to a maximum of 750 per dose and 1500 max over a treatment course. So ferric carboxymaltose, one of the later newer generation IV irons, or a placebo only, no ESA in cancer anemia. So this graphic shows one of the cuts of their data and how fast time to decrease by 0.5 hemoglobin or more. And you see in the orange, the placebo people went down faster than the IV iron people who went down less fast, and the value was significantly different. A different study, same concept, IV iron only. This one's called Profound. So this is a phase 3 randomized open label, 2-to-1 randomization. Here there's going to be a control, IV iron isomaltoside, also called ferric diisomaltose, or oral iron. You would expect the oral iron not to do much because we keep saying how hepcidin won't let it in. This study had adults on chemotherapy with at least 2 cycles remaining. Again, treatment for non-myeloid malignancies, getting treated, chemotherapy. Had to have a hemoglobin less than 12, transferrin saturation less than 50, and a serum ferritin of less than 800, although not iron deficient. Remember those definitions. So we presume these are iron replete, but functionally iron deficient. So they were randomized to receive a total dose of 1,000 over 15 minutes, or bolus injections of 500 given over 2 minutes, or the oral iron. And here, let's go down the left-hand side first and go over to the graphic. So we'll hit the bullets that are highlighted. The IV iron superior to the oral iron in time to response. A better decrease in patient mean fatigue scores, so they felt better with the IV versus the oral iron, and better tolerated. Those of us who've given oral iron, especially as you get to seniors and seniors who are inflamed with cancer, whose stomachs don't want oral iron, don't tolerate so well. I tell our house staff, if you give an inpatient who's by definition almost inflamed, cancer patient on our cancer ward, oral iron, you either don't like them or you want to cause cramps and constipation. So it does do that if you're giving it to someone who's got high hepcidin, not going to absorb. By the way, I hasten to mention here that oral iron in the standard setting, let's say someone with heavy menses, you just want to give some oral iron, it's actually better absorbed every other day than every day. And the reason is this hepcidin thing. When you take an iron pill today, this is the healthy outpatient, maybe heavy menstrual female. You take an iron pill today and the body says, oh no, too much iron, don't want it. Hepcidin bumps up a bit. And so you take your iron pill tomorrow, hepcidin blocks it. You take it tomorrow, it blocks the next day. You take it the next day, blocks the next day. So we now think it's best to give in the healthy outpatient setting, I'm not talking cancer now, oral iron every other day for the reasons of hepcidin. So back to the same Profound study where the graphic shows there's a bit, it's overlapping, but you can see the blue error bars are superior in hemoglobin response to the red bars, and the transferrin saturation also better, so better availability of iron. In this next slide, let's look at some of the irons we've been talking about, the available IV iron products, no more Imferon from yesteryear. So here we have iron dextran, Amoxitol, sodium ferric gluconate. Interesting, while I see the Amoxitol, this used to be an IV contrast dye for MRI. So it's not anymore, it's used in this different indication, but you want to warn your MRI reader if your patient's recently had Amoxitol, it's iron, it's magnetic, there's no harm to patient or to anything, but it'll be brilliant on the MRI screen when the radiologist is reading. They may wonder why everything's so bright. You warn them they just had IV iron for Amoxitol. All right, so in this page, we're going to see another one in a second. Iron dextran, it's always low molecular weight iron dextran. And here across the top, dosing, approved indications. Can you do TDI, total dose infusion? Are there some adverse effects and warnings? So you can give really any dose of this iron dextran. While it's not labeled for total dose, it has plenty of data to do that and is done often that way. It requires a test dose all the others do not. And as I'll show you coming up, while all these things are mentioned with regard to here at the right-hand columns, adverse effects and warnings, it's actually quite rare to have a severe reaction from any of these irons. We'll talk about the fishbane reaction in a second, but the anaphylaxis is quite rare. For Amoxitol, can be given 5-10 is the label, over 15 minutes, often given 2 doses a week apart. You see 3 to 8 days. Can you do a total infusion? Yes, not labeled for that, but there's data for that. You see some uncommon side effects. And the sodium ferric gluconate, 125 per dose, takes a little longer to give. This is popular in dialysis units. No total dose infusion recommended here, and some possible small chance reaction. Iron sucrose on this next slide. You have 3 to talk about here. This is given 100 to 400. No total dose infusion recommended. I'll mention, underline here under adverse effects and warnings, hypotension. The sponsor reports as long as 4 hours later. In fact, I've just recently had this happen, of course, to a clinician, a doctor who got treated, had a near fainting spell some 4 hours after she got this IV iron sucrose. Pretty uncommon, but our nurses are asked to watch the patient for 30 minutes afterwards to be sure there's no drop in blood pressure. And then, of course, a phone number to call in case you feel dizzy, et cetera, on the way home. Pretty uncommon, but just that's the way it's given. Ferric carboxymaltose, you see here you can give it per kilogram measurement or a 750 infusion. You can repeat it in a week. There have been studies giving it a total dose infusion. Notice we're going to come back to in a minute, hypophosphatemia. This is a curious side effect for reasons you'll see. You have to put on your nephrology hat in a few slides from now to talk about the hypophosphatemia. And otherwise, the rare sometimes reactions. Ferric diisomaltose, you can give 1,000 over 20 minutes. It can be a total dose, and the rare reactions. And this just slide makes the point again, these next generation, and you see them below, ferric carboxymaltose or Amoxitol, ferric diisomaltose. Here's the severe hypersensitivity rate, 1 in 1,000, 2 in 1,000, 3 in 1,000. It's at least that rare, if not more rare, as you see from some meta-analysis on this third bullet. So while it can happen, life-threatening or severe, pretty rare. There are some reactions called the fishbane reaction coming up. So here it comes. Any medication intravenously can cause a reaction. And so we are going to go through, Dr. Fishbane, nephrologist, I think does not like that it bears his name because he does not, it's a shame he has to be associated with a bad reaction, but it's good to know. And he first described it. You get, within 15 minutes, achiness in the joints, muscles, and flushing, and sometimes a chest tightness or feel like a shortness of breath. It's a so-called complement activation-related pseudoallergy, getting the name CARPA, complement activation-related pseudoallergy. What about infection? So not surprisingly, we've mentioned this because we just said early on that the nature is playing with hepcidin, inflammation, cancer, hide the iron. And so you give IV iron, are you promoting infection? Well, that's been studied, and the answer is no, because we think what's happening here is in the infected state, too much iron, you're maybe feeding the infection, but so the suggestion at the bottom here is avoid it in cases of active infection, but does it promote infection in the patients not infected? No. And dialysis units really have proven this because they give IV iron all the time. And there's barely an uptick in infections in dialysis units, therefore. All right, so we'll get into, with all this data you've been hearing, what do guideline expert consensus guidelines say about how to manage CRA and CIA? So let's start with the NCCN. I'm just going to do the top 2 because it's the 2 things we keep talking about. They say absolute iron deficiency is less than 30. Remember, in the inflamed patient, you could consider less than 80, and transferrin saturation 20% or less. So 30, 20, or less, consider iron supplementation. You might be an outpatient well, oral iron every other day, or someone who's would rather have IV iron or not well, that is readily available and easier to do and one and done. And the second thing I want to point out is the functional iron deficiency. Here the ferritin is not low. So I propose maybe take 100 as your definition or higher, and your available circulating iron is low, under 50%. Here now, we think you have iron, and you would consider giving an ESA to mobilize it, but it's locked up. Remember, you have it, but it's not available. So you give IV iron to make it available to the erythron. So that's NCCN. How about ASH and ASCO? So there was expert panel review, some 15 meta-analyses, randomized controlled trials. And this was from data during 2010, essentially the 2010 decade, almost to the end of 2018. And adding iron supplementation to ESA, remember, we think IV, improves response and reduces red cell transfusion. And again, highlighted in red, it may improve hemoglobin response and reduce red cell transfusion for patients receiving ESA with or without iron deficiency. I should mention giving ESA to the iron deficient, absolute iron deficient, is really not indicated. In fact, in those patients that are absolute iron deficient, they generate huge levels of ESA already, or erythropoietin, and you won't help, you just need to give them iron. All right, so there are ESA biosimilars, same recommendation. I believe they're safe, it's the same. They're called biosimilar because your brain thinks they're not as good, they're similar. They actually are well studied, well controlled, and I think easily as effective as the branded product. And the myelodysplastic syndrome, not something we're talking about this presentation, but their ESAs can help. Of course, you want to be sure the patient's not iron deficient. And here, the EPO levels, the more they're under 200, the more the ESA might work. And then finally, the Esmo, European Society of Medical Oncology, their update recommendations, who should receive iron supplementation? Well, certainly absolute iron deficiency, as you see here. If you're, once again, high iron, low availability, the functional, then you would consider ESA with IV iron. Monotherapy, as we've said, can work, interestingly, and makes sense because you're going around the hepcidin lockup mechanisms and giving it right to that poor erythron, which is looking for iron. And they mentioned some iron dosing here at the bottom. So let's bring it into the clinic. Let's talk about a case. So BK is a 44-year-old female who was recently diagnosed with HER2-positive early-stage breast cancer. She received 6 cycles of adjuvant TCHP, HER2-positive. She'll have surgery in the near future. Therapy is considered curative. I think it's kind of mentioned here because ESAs for anemia not recommended in the curative setting. She presents to clinic today with lethargy and fatigue that has reportedly worsened in the 2 weeks since her last infusion of chemotherapy. Laboratory results reveal hemoglobin 8.6, ferritin 9, transferrin saturation 9%, reticulocyte count 0.4%. So what's the matter here? Well, the key here, that ferritin. She's anemic. Both the ferritin 9, the transferrin saturation 9, of course, reticulocyte count is low, and she's iron deficient, and she would benefit from iron. And because she's inflamed with cancer, poorly absorbed orally, she's going to need IV iron. I hasten to mention here, we oncologists shouldn't forget our hematology hat. I teach this all the time in the inpatient setting to our house staff who simply, I kid them, their workup of anemia is type and cross 2 units for hemoglobin 8. Don't forget to send the retic count, so important. And the retic count here was low, underproduction for iron deficiency. So what's the most appropriate step for her? Of course, I've just given you the answer. Red cell transfusion, IV iron monotherapy, oral iron poorly absorbed, ESA monotherapy, not a good idea in the iron deficient patient. She needs, in her inflamed state with cancer, IV iron monotherapy. And this is taking this graphic out of the NCCN guideline. She's here. She's ferritin less than 30. She's transferrin saturation less than 20%. She's AIDA, absolute iron deficiency anemia. In the inflamed state, consider IV iron. All right, let's try this case. AP, 76-year-old male, diagnosed with stage 4 colon cancer 1 month ago. Systolic blood pressure between 90 to 100. You order labs, discover he has absolute iron deficiency, ferritin is 19. Transferrin saturation 4%. He's anemic, hemoglobin 7.8. Iron sucrose is avoided. Remember that potential hypotension. He's on the lower end of blood pressure. A larger single dose of iron is recommended for this. Ferric gluconate is avoided. It's not a high dose, it's 125. You recommend 1,000 milligram IV iron using ferric maltose over 20 minutes. However, 5 minutes into the infusion, there's a reaction of flushing, chest tightness, and lower back pain. What's going on? Your choices: discontinue IV iron, do not restart. Hold infusion, restart with different product. Hold infusion, restart with the same product. Manage severe hypersensitivity, start oral iron once he's stable. Well, this is the fishbane reaction. So it's a quick thing. It's not anaphylaxis, not life-threatening. Sadly, I actually did this to my daughter, who was iron deficient and had this reaction. You take your own pulse and take her pulse and reassure her, and sure enough, in 15 minutes, it went away. And you actually can start the same product again within about 15, 30 minutes waiting for the reaction to dissipate. It should go away. All right. And here actually is some more information. This CARPA, complement activation related pseudoallergy, resembles but is not anaphylaxis. To remind you, facial flushing, you get red. You may have some chest tightness, low back pain, may make shorter breath. Wait about 15 minutes until it's resolving, 15 to 30. You may start the same IV iron product at a slower rate. If it's bothering you, bothering the patient, especially if there's hives, you can give an H2 blocker before the rechallenge. You might consider steroid. We actually don't recommend things like Benadryl, H1 receptor antagonists. They can just zonk your patient, and it's going to dissipate with the steroid and some H2 receptor antagonists. You'll be okay 15, 30 minutes later. Total dose infusion. So here are some names you've seen before. Iron dextran, always low molecular weight. Amoxitol, ferric carboxymaltose, ferric maltose. Is it on label? Has it published data? So TDI on label, no for iron dextran, but in fact, it's well known you can do this fairly rapidly after your test dose. For amoxitol, yes, even though it's 5, 10, twice in a week, you can data to support the 1,020, 2 doses. Ferric carboxymaltose, it's labeled and you can do it. And ferric maltose, yes, it's labeled and you can do it. So phosphorus, I warned you we're going to have to put on a little renal hat, and here it comes. So just to background, phosphorus distributed widely throughout the body, many physiologic functions. Of course, DNA, triple phosphates, DNA, RNA, we need it there to make those. Enzymatic functions, hydroxyapatite crystal, mechanical strength, you get the idea, we need it. Normal levels are 2.5 to 4.5. And it's not routinely measured. Actually, it can change a bit from early to late in the day. And 1% of our total body phosphorus is found in extracellular fluids. Likely the rationale for minor deficiencies, which are asymptomatic. So there's the background. All right, so a new name for us hematologist oncologists, fibroblast growth factor 23, abbreviated FGF23, has to do with parathyroid hormone, vitamin D metabolism. So this molecule here in the middle, FGF23, turns out if it's elevated, it will cause you to waste phosphate. Urine phosphate wasting at the tubular level. Ordinarily, when this is low, you absorb phosphate normally. If it's high, you won't. It also, to the right here, interferes with vitamin D metabolism. To the left here, interferes with parathyroid and PTH metabolism. So high FGF, not a good thing for bones and for your phosphate level. All right, so here on the left graphic, panel A, when your iron is replete, FGF23, not a problem, all's good. Turns out, if you're iron deficient, this can rise and do the things I mentioned in the previous slide, causing phosphate renal wasting and vitamin D, PTH, bone metabolism abnormalities. Well, surprisingly, one of our IV irons, ferric carboxymaltose, does raise FGF23 and can cause these things: renal phosphaturia, bone metabolism, vitamin D, PTH. What's the data for that? So this is entitled the Phosphere Clinical Trial Program, ferric maltose versus ferric carboxymaltose, the FCM. So there were 2 trials, over 100 each, either getting ferric maltose or FCM. Incidence of hypophosphatemia at a certain point, 1 month, was measured, and hypophosphatemia was called less than 2. And the results are shown here in bold at the bottom. In these 2 trials called A and B, the incidence of that parameter, phosphate less than 2, was, we'll call it 8% in the ferric maltose versus 75% FCM. And we'll call it 8% again in the ferric maltose versus 73% the FCM. So it happens. Severe, less than 1, where the patient would have quite significant symptoms, was lower in the ferric maltose versus FCM, actually 0, and 11%, so potential severe low phosphate in the FCM. This all has to do with the FGF23 mechanism. All right, we're ready for our post-test. Hopefully your brains are bulging with what you've learned, and we'll go through those initial questions and then give you what we propose our answers. So our first one, you remember JL presents to your clinic reporting fatigue and general weakness. You order labs, which reveal her serum ferritin 345, serum saturation 14%, hemoglobin 8.6. You diagnose JL with which one of the following: absolute iron deficiency, functional iron deficiency, iron overload, anemia without iron deficiency. All right, so if you're experienced test takers, you know the ferritin is way high, so A is wrong. Absolute iron deficiency, she's not. D, anemia without iron deficiency. Well, yeah, but that's not the best answer. Iron overload, it's not that high, so answer B. This is classic, typical anemia. Transferrin saturation, available circulating forms are low, but iron stores are high, 345. So you would diagnose functional iron deficiency anemia. Remember case number 2. For patients with cancer-related anemia and/or chemotherapy-induced anemia, IV iron has been shown to achieve which of the following: reduce transfusion requirement, increase erythropoiesis, enhance energy, activity, and overall quality of life, all of the above. So remember from many of our previous slides, in CRA and CIA, IV iron and either mono or with ESA did all these things. So yes, it does reduce transfusion requirement, increase erythropoiesis. Of course, you're feeding that bone marrow with a readily available source of iron. And we showed that the quality of life improves as you respond with increase in hemoglobin. So it's all of the above. Next question. In a hyperinflammatory condition like cancer, hepcidin levels are often elevated. Which of the following iron supplementation strategies aims to address this common finding in CRA and CIA? So which addresses the hyperinflamed high hepcidin level and supplementation? So 4 answers. The first one, oral iron should be used preferentially in higher doses to overcome reduced intestinal absorption. Intravenous iron should be used preferentially as it circumvents reduced intestinal absorption and overcomes restricted ferroportin transport. Oral ferric formulations are preferred as hepcidin only disrupts oral absorption of iron in the ferrous form. Or oral iron should be used preferentially due to patient tolerability. So I think all of us are probably experienced test takers, having gone through high school, college, medical school, nursing school, etc. And so you notice 3 of these answers have the same beginning: oral iron, oral iron, oral iron. And if I've taught you anything, today, the oral iron in the inflamed state is so poorly absorbed. So the one answer which is different is intravenous iron, and that's the winner. So intravenous iron should be used preferentially as it circumvents reduced intestinal absorption and overcomes restricted ferroportin transport. I love that answer about changing the ferric to ferrous, of course, to tease you. It's the only one without oral, it's venous, is the answer. Next question. Which of the following is true about IV iron safety? Severe hypersensitivity reactions are extremely rare with next generation IV iron products. Next, Fishbane or the Karpa reactions should merit treatment discontinuation. Molecular weight has minimal impact on the safety of IV iron. IV iron can generally be used without concern in case of active infection. Well, let's go through them. Severe hypersensitivity, rare, extremely rare with next generation IV iron products. I think you'll recall that that's been a theme of this presentation, so that's the answer we like. The Fishbane or Karpa reaction should merit treatment discontinuation. Well, we've said if you stay calm, your patient gets over the reaction and restarts slower, so you don't have to stop or change product. Next wrong answer, molecular weight has minimal impact on safety of IV iron. Actually, the Infron was high molecular weight, Dexferrin was high molecular weight. Those were rather unsafe. And so it does make a difference, and those are off the market. IV iron can generally be used without concern in case of active infection. Remember, we're going to avoid IV iron when you're actively infected and try not to feed the bacteria that are looking for iron. All right, our next question. JL returns to your clinic after 3 weeks on oral ferrous sulfate, hopefully every other day. She reports bothersome stomach pain and constipation, says she still feels tired all the time. Remember those pains and constipation in the stomach. When you recommend IV iron, she asks about potential treatment-related risks. Which of the following accurate patient counseling points regarding IV iron associated phosphatemia or renal hat? So which of the following is an accurate about, which is true about IV iron associated hypophosphatemia? A, hypophosphatemia is not a clinically relevant consideration when selecting IV iron. B, trial data suggest the greatest risk for low phosphate among currently IV iron products is with ferric maltose. C, trial data suggest the greatest risk for low phosphate among currently available IV iron products is with ferric maltose. D, serum phosphate monitoring is only warranted in patients receiving IV iron for anemia of chronic kidney disease. I like that last one because you go, oh, maybe that's true. But remember our last few slides moments ago. Strangely, the ferric maltose affects the FGF23 system. And so you can get significant, remember 11 went less than 1 serum phosphate. You can get a significant low phosphate with that particular product in a small but not significant proportion of patients. And so we've come to the end of our optimizing cancer-related anemia outcomes in the community setting, interprofessional approaches, and evidence-supported strategies for improving care with intravenous iron. I hope you've enjoyed this presentation as much as I've enjoyed giving it. We welcome getting back to your questions and answers if you have any.